Hello everyone. Okay, good day. I won't take much time. Thank you for participating in this CME. So I'm Dr. Anand. I practice in a private practice. So in my practice, I do apply hypnosis as part of my modalities anesthesia. So there's two things I do: acute medicine, anesthesia in OT, and also chronic pain care. So in today's slide, I'm going to briefly talk about the anatomy, the basic science behind hypnosis, how it affects the brain and how it affects the pain pathway. I'm going to share few videos on my practice with some patients that I have on hypnosis. So for good comprehensive pain management, it's a multidisciplinary, multimodality model to treat pain in a better way. So it addresses biological component, physiological component, and psychological component. So most of the time we are trained to handle the biological component with pharmacological agents. So the pain experience itself, we have a lot of pharmacological tools, drugs. Emotional and modes of patient's experience. For example, there's a fear of the pain itself, fear of exercising, fear of rehabilitation. So that component most of the time it's not looked at, and this can be supplemented by psychotherapy or complementary adjuncts. Another part of pain management is the behavioral component, social aspect of it, which is the cognition part of it. Some patients may have a feeling that since I have pain, I am not able to move, and they develop a maladaptive behavior because of that. So these two components are the part where we all know pharmacological agent has minimum influence, but is a major component in their healing process. So in this paper, it has been postulated, the neuroscience basis of hypnosis, there are three main brain neural networks that's involved in hypnosis phenomenon: the salience network, default control network, and the executive control network. The salience network basically comprised of the dorsal anterior cingulate cortex, insula, amygdala. The default cortex is posterior cingulate cortex, executive control, dorsolateral prefrontal cortex. A lot of names there. Huh? So basically what it means is the salience network is a part of the brain which decides what is important or not important. Should the patient or should I be focusing on something? So once this part of the brain decides on that, it will send signal to the central executive network or the default mode network. For example, let's say we are watching a movie which is entertaining, it will send signal to the default mode network to say it's not important. The mind can start wandering, daydreaming, sense of self, creativity, and diffuse attention, which we all have during lectures. Another part of us is salience network when we are focusing on an exam. So it's a very focused state. So the central executive network comes into play, narrow focus, self-control, problem-solving mode. So this has been well researched and published in this paper. So what this simply means is the salient network decides which part of the brain to be in play. So the default control network is the part of the brain which says daydreaming. So it's active when a person is not focused on the outside world rather than the inside. Is a part of the brain which is active during wakeful period, rest, daydreaming, mind wandering, involved thinking about others, thinking about oneself, remembering the past, envisioning the future. It is turned off when we are active at work, when we are processing tasks. The executive control network, the dorsolateral prefrontal cortex, is an externally directed cognition, active when we are involved in high-skill work. A set of cognitive processes that are necessary for the cognitive control of behavior involved in planning and decision making is turned on when decision making is required. So how does hypnosis affects the neurobiology of the brain? Hypnosis disconnects the posterior cingulate cortex, which is the default component, involved in self-reflection from activity in the salience network, dorsolateral prefrontal cortex. So what this means is it simply means that a person do not worry about things that is going on. It helps to reduce exaggerating pain response. Simply means that a person does not ignore the pain but lessens the pain. So hypnosis is not a way to eliminate pain, but it lessens the person's response to pain, and with pharmacological agents, it supplements this process better. So this is a patient which has, I think we all face difficult IV cannulation. A lot of patients has chronic pain when it comes to bad IV experience. So in this video, I'm going to show you how I induce hypnosis very fast to insert IV cannulation. We all know when a person about to be pricked in the hand, the response, the facial response will tell a lot. So let's see. So what I do is basically I get a person to focus on the movement of the hand. So by focusing on the movement of the hand, they start to daydream. So if you notice the eyes, she seems to be sleeping, but actually it's not sleeping. She's just inwardly focused inside herself. So this lady is planned for a cesarean section, but she has 3 previous cesarean which end up with death of the baby. So it's traumatized her. So for her, Caesar means death. So any IV cannulation is death. So no one could insert IV line because of the fear. So the way to hypnotize her was I helped her to focus on the sensation in her hand, get her inwardly focused, and if you notice, the heart rate never changed. So she's quite comfortable. The Branula is in, and she appears to be sleeping, but she's not sleeping. She's quite aware of the environment. So what does hypnosis do actually to patient? It induces an independence among the brain region, meaning that it separates the brain component of the brain functions. Because the brain is unable to synchronize communication, hypnotic states which you observe just now, they seem to be inwardly focused. That happens. And when that happens, it facilitates suggestions, which is typically not available in normal state. So this shift in function could explain the behavioral change which you saw in the video just now. So another paper, can words hurt? So we all know when we insert Branula, for example, simple procedures, I'm just referring to simple procedures. Branula, we always say you're going to feel some pain, you're going to feel some hurt, you're going to feel this. So these do inflict pain before even the pain response starts to kick in. So in this paper, it has been discussed, many papers like this, words do have affective component in pain perception. So language has a role in forming experiences for patient. So positive languages such as relaxation induces calmness to patient, and this is what we call conversational hypnosis and a tool for effective communication. So how does hypnosis work is in tandem with these words. So we all know chronic pain. There's something called pain neuromatrix. Pain experience is not from one particular part of the brain. It is not activated from a single region, but rather from various parts of the brain interacting together. And that is why there's a dimensional component to nature of pain itself. So the pain processing activates a large area of cortical and subcortical network, the primary somatosensory cortex, secondary somatosensory cortex, anterior cingulate cortex, insular, the prefrontal cortex, cerebrum, thalamus, whole wide range of areas. So in this paper, the effect of hypnotic pain modulation on TMJ disorders. So what has been said is chronic pain activates key regions of the corticolimbic system, which are intertangled with regions of the pain matrix itself. It simply means that by using hypnosis, in this paper it says that hypnosis can alter the various networks, the default mode network, external control, attentional processing, anxiety processing component, and the sensorial component. Okay. So in this paper, it shows that cognitive hypnotherapy for pain management has a role. All right, I'm going to show you a quick video. This video, this gentleman, he is planned for cataract surgery. So normally cataract surgery is done under topical anesthesia. But 2 previous surgeries failed because the moment he lay on the table, he jumped out. He can't tolerate the claustrophobic environment itself. The moment the drape is on, he can't take it. He's not fit for anesthesia because he has developed severe anaphylactic reaction to to lignocaine infiltration in the past. So he has this thing, I need the surgery, cataract. He's only 45 years old. He has mature cataract secondary to chronic use of steroid to overcome the allergic reaction that he has. So the eye is important, yet I can't go for surgery because I have all these issues. So we discuss hypnosis could be an alternative. So he agreed to that. So there are two components here, pain and the surgery itself. So the first video is about he going through the hypnosis for the venipuncture, Branula, and after that during the OT. So I get him again to focus on the sensation around the hand. And as I get him to focus on the hand, I continuously give him cues, relaxation, suggestion. And if you notice, the hand is not moving because he's already inwardly focused. He's not concerned with outside world. So yes, he's aware of me applying tourniquet, doing all those things in the hand, but he's dreaming of something else more important. So in this case, I actually made him think of getting the eye vision back to normal, going back to his normal life. So that is very important to him. So focus on the eyes. He as the needle goes in, he's quite relaxed. So he didn't move, he didn't pull his hand, quite comfortable, easy to put in the cannula, easy to draw blood. So none of the blood investigation was done in the ward. We can't do, he didn't allow. So he's relaxed, all right. So for chronic pain hypnosis, when I use hypnosis for chronic pain care in my practice, I look at a few components. So we all know that it's the transition to chronic pain is marked by a shift in pain representation from sensory to emotional cognition. So chronic pain patients display maladaptive behavior that can lead to pain avoidance behavior, mood disorders, negative pain beliefs, and poor global quality of life generally. So what hypnosis does is it targets areas of the corticolimbic system, thus altering the emotional processing of the pain and the sensory aspect of the pain itself. But for some patients, it does reduce the perception of pain or the quality of pain itself. So what does hypnosis being defined as? In 2014, American Psychological Association defined as a state of consciousness involving focused attention with reduced peripheral awareness characterized by enhanced capacity for response to suggestions. So there are three components here. Absorption, meaning that to get the patient focused attention on an experience. Disassociation corresponds to mental separation of usual state of mind. Suggestibility, meaning that to give suggestion to patients to relax, to suspend their critical judgment. So the basic method for hypnosis and pain management, there are three components which I normally do. The induction phase. Induction means getting them into a focused state of attention. Therapeutic suggestion. Therapeutic suggestion means telling that we do not use the words that do not focus on pain, because that's where the pain will be focused. So use things like you'll be going back to home soon, you'll be eating back normal, you'll be walking around the ward, pain medication will be given, don't worry. I mean, those kind of things, positive thoughts. Then teaching self-hypnosis skills. So depending on type of surgery, type of pain, the teaching can happen weeks before the surgery or even on the day of surgery. So induction here means to help the patient relax. The second phase is provide suggestions. Emergence from hypnosis means simply getting the patient back to normal state of awareness. Hypnosis method, there are many methods. So in this paper for plastic surgery as an adjunct for conscious sedation, two commonly methods practiced mentioned here is sensation focus method, focusing on a particular sensory or imagination of a relaxing place. Okay, this is this patient. He has chronic leukemia, he has chronic pain, plus he's retroviral positive. his plan for bilateral cataract procedure because of dense cataract. He can't tolerate local anesthesia alone because his baseline heart rate is 140 to 150 when the moment he lies down. So again, the same approach. Hypnosis offered. So this is 2 hours before surgery. So what I do, again the same method, focus on the sensation in the hand. So I ask him to feel numbness in the hand first. So the moment he feels numbness, then he will go into his own relaxation process. So this state is already inward state, meaning that he's aware of the hand movement, he's aware of his dreaming state, but he's not concerned with outside world. He's just relaxing by himself. So I do this, the moment the hand falls down, he's asleep. So I get him practicing to do this, to build his self-confidence that he can do this, to keep him in a comfortable state. This man is planned for, he has severe carpal tunnel with traumatic hand injury. He refused to go for rehabilitation process, physiotherapy, because his hand will always be painful. So they asked for my help. How can we help him to participate in physiotherapy rehab for his hand? So I make him imagine holding the exercise stuff and squeeze it slowly in his mind. He's not physically not doing it because he has the perception, if I physically do it, I'm going to have extreme pain. So we remove the real thing, practice in his mind. So he can hold that. Prior to this, he can't even straighten his fingers. He has the perception that my hand is useless. So the moment he can do this, he has a perception that I can bend my fingers, therefore I'm okay. So that's the first step into his process of healing. Then I will teach him how he practices the self-hypnosis by himself to reduce pain. So throughout the whole process, if you notice, in my method, I use hands a lot, simply because when they walk into the hospital, hands are cold. So there's a really cold perception there. So I utilize that. Cold is abnormal pattern. They do not have this at home. So they have this in the hospital setting. So I utilize this safe time for me. Okay, this slide is about a person. She is a 50-something years old lady. She's planned for OGDS because of upper GI bleed, but hemodynamically stable. She has severe asthma. On that day of scope day, she has chronic wheezing, very bad wheezing. And so there's a concern. Sedation can cause respiratory issues. There's also a concern from the surgeon that if I put in the scope, she's going to react and going to get bronchospasm. So what can we do? So I use hypnosis, and normally we can supplement minimum sedation. But in this lady, we didn't use any sedation, but I use a lot of local spray. Most of the time, if someone who has asthma, there's certain fear if we spray, they can trigger asthmatic attack. But they're already spraying MDI. So that fear is not warranted fear. So if we manage that fear, they can go through. So the OGDS is relatively fast, simple procedure. So hypnosis helped her in this way. Let me open the slide. So I got her permission to allow the face not to be blank so that we can see her face. So I use again the same method, focus on the hand. So as she's doing that, then I quickly spray into her mouth, local anesthetic spray. So she's not reacting towards the spray negatively, so that's good. So I give generous amount of spray so that she feels the numbness. She can communicate, she can talk. So any verbal response is encouraged. So I get her to imagine she likes by the beach, seaside, relaxing there. She didn't like the taste of it, of course, but she can tolerate it. So that's the idea. How long does it take? It takes about 20 to 30 minutes to prepare her. Because my aim here is not to give her any sedation at all. Right. So once she's ready, she goes in. She can cooperate with the people around her. She can obey commands. She's interacting with staff. And as they're preparing her, she's going back to her own mind relaxation process. So normally we all know that when the scope is being put in, the initial part there will be gagging. That is a difficult part for surgeons to pass through the scope. So in her case, she didn't gag. So if you notice, the scope will go through. Once it reaches the vocal cord area, it will just go through smoothly into the esophagus. She didn't gag. Is she awake? Yes. The surgeon will be talking to her all the time. So helped her. She recovers faster. No sedation required. No asthma-like symptoms throughout the whole process. Yeah. All right. That's all. Thank you so much.